Welcome back to Ascension Medical Educators, where mentorship and mastery unite to fuel your success in medicine. I am your co-host and moderator, Dr. Darren Wayne Jackson II, and I'm joined by my co-host and expert facilitator, Dr. David Leon Taylor.
Welcome back to our aspiring physicians once again.
Yes. So today we have a treat. Session 1, orientation.
Yes.
Session 2, no more orientation.
That's
Is
right.
down to the gritty, to get the works, right? Now we have finished step 1. We have completed our preclinical years.
Yes.
And now we get to wear that white coat or those scrubs. We get our scrub access.
That's right. Get to go access to the hospital.
Yes,
special badge.
And we're on our way to the wards. So it is clerkship time. So this is facilitated session 3, where we are talking about the Clerkship Playbook for success. All right. How do we navigate the wards and our shelf exams that we see at the end of our rotation? So DT, let's jump in, and first let's talk about what can some of our student doctors expect or should have in mind to practice, to put in play on day 1 of clerkships.
Day 1 of clerkships is always a big transition, DJ, because there are a lot of unknowns for our scholars. They feel kind of excited and at the same time a little nervous. My first day on the wards, and everyone's looking and ready for you to interact with the patients. And so we should think through some core skills. There's an expectation that every medical student should be able to engage a patient. And I'm going to have you reminisce for our aspiring physicians, and of course, our current medical students who are getting ready to move to clerkships, what it was like for you. What is the actual expectation on the first day? What were you expected to do?
So on the first day, we were expected to, be able to take a history and physical.
Yes.
So that's key, to be able to, engage your patient and communicate and take a proper history and physical, because a lot of that information is going to be where your clues for your differential diagnosis will be, right? The second thing is then you have to be able to prioritize, like I said, the differential diagnosis. So scale that differential diagnosis, right? And so a lot of times when we was looking at what could potentially be going on with our patient based off the history and physical, we are putting our differential down, but then we're also numbering them to kind of figure out what is the most likely case, right? Then we want to talk about what are the recommendations, like the interpretations. So we're expected to be able to look at basic labs, basic, imaging and things of that nature, and be able to not only interpret them, but also effectively communicate them, right?
Yes.
And then one of the big things, and, it can be a little daunting at first for many students. I think that this is where, I was a little excited because I'm a talker. So, but the presentation
presentation to the attending physician or your
resident is a big and major thing. And so there's, we was prepared on, the different ways in which you can make the presentation. And, there's different formats for that, but that's a big thing. And then that last piece, man, now this last piece tore me up during medical school was the note, man.
That's right.
You got to know how to write a note. And
medical note.
Yes, medical note taking, it's very important. And not only write the note, but be respectful in your documentation. Be accurate in your documentation. And all of these things, kind of works simultaneously. If I'm giving an accurate documentation in my notation, I had to be able to effectively take a proper history.
Thank you, Dr. Jackson. Right? That's right.
So all of these things, again, they triangulate, they come in circle, but these were some of the expectations day 1 that we were expected to have when we went into the wards. Now, DT, break down a little bit more, because these are the expectations, you
Yes.
know, we look at as students, like, this is what we have to do. But from an administration standpoint,
Yes.
what are these things framed as? Give us a
That's
little bit
right.
more information.
That's the big picture. And that's what I was hearing as you were explaining it. All of these skills and competencies are known as entrustable professional activities. Entrustable professional activities, EPAs, committed to memory, because as you know, DJ, you will hear that over and over again now in your clinical engagements throughout your wards, and of course in residency, and then on into the rest of your physicianship. You are being entrusted now as a professional with very specific clinical and other activities that support patient care. And as we heard Dr. Jackson note, that encompasses effective communication skills with your patient, how you build relationship with your patient, confidentiality, a synthesis of all of the preclinical science and other information related to culture, cultural humility, cultural competency, patient population statistics. All of that comes together and is in your mindset as you take an effective history and then use the information to target your actual physical exam and then assess what orders in terms of imaging, labs, etc., do you generate, right? How you look at all that data, synthesize it with the history and all the other information, come up with differential diagnoses, and then you get to present all that to a resident or attending physician. All of that is part of your skill set. And as we talked about in the previous facilitated session, competency-based education, the skill now is known as an entrustable professional activity.
Man, so these EPAs,
Yes.
these are guidelines, or, you know, expectations for the most part, that administration, or just, you know, the overall governing body, because a part of your professionalism as a medical doctor is to be able to have these skills very hardwired, because that is your toolkit for good quality, gold standard patient care, right? And so at the beginning of every rotation, you do want to look at your course outline. Those course outlines gives you an idea about what that course is about. And then it allows you to then be able to make certain goals for that rotation. And that's very important in that beginning, setting a goal for the rotation at the beginning, because it allows you to then be able to align your rotation goals with the EPAs, you know, and that's just similar to what we discussed in previous facilitated sessions when we're outlining the course objectives and taking that and you know, and correlating it with our primary resource and whatever secondary resources we have. So similar to that, we are able to set a rotation goal, and anytime we're planning and doing the preparation work beforehand, it's increasing our chances of success. So we're doing that, and we're aligning it with the EPAs that administration and just what the professional bodies of medicine, governing bodies of medicine, is expecting us to have when we're doctors. So having that is a very strong thing. Now, that's kind of like my reasoning and logic with it. But can you give us some quick strategies, or a takeaway strategy that some of our student doctors can have in mind when it comes to these EPAs and how they apply during those clerkship years?
Yeah, I love the way you brought that together, DJ, because you're showing, in essence, the synergy again of how we learn.
Right.
And now we're doing learning and patient care together. And so a key pearl is, at the end of each day of your clerkship, a short reflection, as you've always talked about. What entrustable professional activity or activities, and there should be many, did I accomplish today? What did I do well? And what's the area of improvement? You can keep that in your journal because we're going to talk a little bit later, DJ, I'm sure, about feedback and the importance of that.
Right.
But that's a great action step to bring everything together and to allow you to, as you said, continue to be proactive in your preparation. Now, your preparation, though, is for patient care as you continue to learn in the clinical realm.
Right. And those reflections, when you just said that, of having that practice of the reflections during your clinical years is very important, and it links it back to what we discussed on session 2 about that emotional tie-in with the story about the flower. You have that emotional aspect of, documenting the information. It gives you that attachment and you're able to retrieve that information. So similarly, when you're on the wards, having that practical or just real life connection, and it works a little bit different during your clerkship years, because now you're not sitting down studying it, most of the time in a textbook. You'll do that some of the time, but a lot of it is going to be experiencing it real time in real life on the clinical wards, on the inpatient wards there in the hospital. So you have that emotional tie-in from that story of that real patient you real person, student doctor, took care of. And it's etched in your mind about the pathology, the different histological unique features, because you saw it in real life. And so these things tend to stick around a little bit more. So I just wanted to bring that up.
That's a great pearl.
Yeah.
That was a great pearl there. I was getting very, very excited about learning.
Right.
Because you just shared a great way that I know you're going to touch on in a moment about how you take the learning on the wards and prepare for, ultimately, there has to be a shelf exam. Right. And one of the things you just did so well from our previous session is you talked about meaningful learning.
Right.
And our patients are actually a gift to us. You have the privilege of working in the most intimate aspect of the human condition, someone's health. And in exchange for that privilege, you also have an opportunity to learn meaningfully. And as you said, as you make that connection, it helps you understand what was happening with that medical condition, so you can help another patient in the future, but it will also help you be successful on your exam when it's time to demonstrate, again, the EPA, the competency related to your understanding clinical reasoning. You just help us look at a good strategy for doing that in real time.
I just want to have a mental health sidebar real quick, right?
I love it.
So what you're saying is very important, because that is very important to really approach this experience of being in medical school and then being on the wards as a privilege, as a gift. Every patient, like you said, Dean Taylor, you're seeing people, other human beings, at their most vulnerable, at some of the most vulnerable points of their lives, right? As a student doctor and as a doctor, you're getting people data. I've talked about this before.
Yes, you have. Yes.
To me, the most important data, right? You learn people, you learn things. And so the mental health aspect about this, and the wellness aspect that you was touching on, is the practice of gratitude and empathy. Okay. Because you can't really get to that point of reflection and looking at your patient as this gift if you don't practice or have empathy and gratitude. So so just having empathy and gratitude closes the gap, and increases your success rate on the wards, just simply by having empathy and gratitude. Because it's through the empathy and gratitude that allows you to be in that space to really lock in on what the needs are of your patient. And then that allows that case and all of the mechanisms that went on, from the ordering to the history and
Yes.
physical to how you had to present to your attending and resident to how you had to document it. All of these things are going to come back a lot more easier because that patient has stuck into your mind now.
Meaningfulness. And I'm so happy we did that important moment because there is recent data that is showing, unfortunately, that our medical students are losing empathy as they go through the medical curriculum, and as they enter residency, there's a decrease in empathy. And part of this, I believe, is associated with, and the data supports it, what you've been talking about earlier, is because of burnout. And when there's burnout, all of a sudden your focus is different. And that's not how medicine was intended.
No. And it's a very, I experienced that, as a medical student, and seeing lack of empathy, you see it, as a person receiving care themselves or having family members receive care. You see the empathy, go. And a lot of times I remember early in my medical school career, I wanted to understand how you get to that point, right? And you brought up an important point. You said burnout. And when you looked at some of the people that you might have questioned their level of empathy or gratitude for the privilege that they have to be someone's doctor, in other areas, you could see why that might have been the case. The burnout, the stress, and you can see it on them. And then that reflects in the patient care. And who loses the most in those times? The patient loses, right? And we don't want that.
Absolutely.
So, there has to be a way where, we are, tying in these real important, just humanistic aspects. That is so important as a doctor, is to have that humanistic aspect, that humanistic mindset about you. Because when you lose it, that's also when that increases burnout. I mean, just think about it. If you're going to work every day and you're just looking at it as this mundane thing of tasks and checklists to do, because medicine can very easily fall into that, because the interactions that you have with your patients might be a very small percent of your day. A lot more of the day will be the administrative work, the note taking, the consults, the talking to other teams. And so if you approach your day as a medical professional, as a doctor, with just this checklist, and you don't even see the humanistic part of your patient, and it's just a case, a lot of things get lost in that. The learning gets lost.
Yes, it does.
The burnout gets increased because there's no emotional attachment to your patient and to your job. It's just a check off for you, And so practice of empathy and gratitude goes a long way, not just in the realm of well-being, but also in learning, also in our ability to give gold standard care to our patients.
A great example of how you talk about things being all interconnected. And so with that understanding, right, you always talk about awareness and mindfulness and taking care of ourselves. This sets the stage for greater opportunity for success, because now, as you said, when you are making those connections, not only is the patient feeling valued and cared for, not only is the patient receiving excellent care, but the way you're learning is optimal. So now when you're preparing for that other competency at the end of the shelf, at the end of the clerkship known as the shelf exam, you can be successful there too, which is one of the, again, Entrustable Professional Activities, is that you demonstrate your learning through a type of assessment, and eventually becomes part of your licensure. So it's a very insightful point that you gave us.
So those are some aspects of success on awards. What are some other things that we can look at? So let's jump into our next topic. So what are some keys to success on the wards that, that our student doctors can take into the wards tomorrow? So when you show up tomorrow, what are some things that, from an administration standpoint, from a medical body professional organization standpoint, would you recommend to student doctors?
Right. So we want to keep everything in that nice sequence that you gave us, because we don't want to lose focus on the keys, of course, professionalism, collaboration, and teamwork as the top, the core expectations of what you have to be able to do to engage a patient, right? The core components of empathy in everything you do, and gratitude across your engagement. So those are at the top of the list already. Now, as you continue, before we get to the feedback piece, a lot of times medical students want to also know, how do I balance seeing my wonderful patients, but also doing independent study, because I have to continue to learn. And we usually talk about 2 brief tips. And I want to hear what you did as well, because again, you are a great model of having gone through the process. But in essence, I call it longitudinal learning, what I keep doing every day, and then what I do on the given day. So my daily learning and longitudinal learning. The daily learning, and once you touch on this for me in a second, DJ, is how have I engaged my patient, and what did I learn in that engagement? But then when you get home that evening, what else did you do as part of that learning process for your daily learning?
Got you. So the wards, when you get there, is a different experience. We already said, now you're splitting time. All right. You don't have just lecture and library. You got, your learning days. So didactic days, grand rounds. Now you're fully in the mix now. You have patient care responsibilities, but you still have the learning piece. And as you go through these stages of your medical journey, the time to just sit down and do learning or studying becomes smaller and smaller and smaller.
That's correct.
So building the skills early in your medical journey is going to be key, because there's going to come to a point where you're not going to have a dedicated period of time to study for step. Step 3, you got to get that in on your day-to-day as a resident. So, one of the things that I did during, my clerkship years to kind of, hone in on the learning and then other various aspects of keys to success was, creating, looking at those available study blocks, and part of that is being proactive as a student. When you first get onto that particular rotation, you're going to get a certain amount of information that's going to let you know different days. Maybe there's presentations that you have to do. So you'll get a good deal of information before you start the rotation. So you know exactly the expectations and requirements of that course. Then once you get that, you get to kind of build around that, right?
I'm hearing time management.
Time management is going to be a big key in your clerkship years. And I knew that. So, and then you also have to factor in travel time, because, many hospitals have satellites. I mean, many medical schools have satellite sites where you do rotations at. So all of your rotations may not even be in the same, on campus. You may, have one rotation on your campus, and then your next 2 rotations may be 45 minutes away, right? So some of the things that I did, going back to that, is just, being realistic about what I can do during the week, during each day. Because sometimes day to day, during rotation, they can change. The days can be different. And so what does that particular day look like? What time and available study blocks do you have during those days? And then also being consistent about locking it in each time that you have those blocks, right? So that was first and foremost. And then some other, just kind of quick things that I did was just making sure I did fit in that balance. When can I go to the gym? Who can I collaborate and study with, those team-based learning opportunities, because you're going to get a lot of that while you're just sitting in the resident room, and the residents are asking you questions, or you're kind of talking with your cohort and fellow medical students about what's going on. So those are just some quick things about what I, on what I did during my clerkship years.
Yeah, I like it.
I can go into some more, and we'll get into some more during,
That's right.
during the rest of the session, but those are just some quick beginning things.
I like it, and it makes sense because what you're helping medical students, scholars know, and our pre-meds as they move toward the medical student phase is that learning in the clerkship years has to be flexible and adaptable. And working with blocks of time, as we always call it, ASPs or available study blocks, it fluctuates because on a given day you could be in the hospital till 7 p.m.
Right.
Some days 4 p.m. So maybe you'll get an hour in the evening at some point, but remember, you still have to rest so you can be fresh because you're now engaging patients the next day.
Right.
So sometimes your learning is actually occurring during the day when you're not seeing patients, but you're in the residence room and you're learning from your resident, or you're learning from another peer in a collaboration. So that's what we mean by daily learning. There's a little routine. And because you also, as you said, you get some structure early on because you get a syllabus, if you will, for your clerkship. When you have certain presentations and certain other requirements, you begin to build around that course schedule.
Right.
Now, one other pearl that we typically suggest for that daily learning is you may have had 3 or 4 patients that day. Whatever the key medical condition was for that day, that's what you can focus on as another area of enrichment. It may happen that night. It may happen when you're in a study room with a resident or another medical student, but that's what you try to do to help focus the learning around what happened that day.
Yeah.
But sometimes there are medical conditions or aspects of the medical condition you never get a chance to actually evaluate, but you're still going to be required to understand it because one day you will see it, and it will be on the shelf exam. That's what we call your longitudinal learning. So every medical student, and we're going to hear again from Dr. Jackson, usually has one resource, one preferred resource for a given clerkship. And that resource, you begin engaging it at the beginning of the clerkship, and you try to complete it longitudinally, just in sequence, a little bit every day, up to about a week before your clerkship ends, because you got to finish it before the shelf exam. Does that sound familiar, Dr. Jackson?
Sounds very familiar. So just,
and it's not easy.
No, it's not easy. And so those are, you get your resource, and you have to, and this is where the daily discipline comes into place, because you have a fixed amount of time. And the shelf exams are there. They're after every rotation. And if your rotation is 2 weeks, then it will be in 2 weeks. If it's in 4 weeks, it will be in 4 weeks. So you have to really be cognizant about your time management when going through those resources. So that is definitely something that, I had to do. A lot of times they will give recommendations on what the resource is, or there will be a fixed assigned resource. And there's typically multiple resources that they will give, in the course catalog that gives the student some idea of some guidance on where to go to the resources. And so that gives you a little bit of framework. So that's the learning piece of some of the stuff that I did. But then there's also a behavior piece, that is very key to your keys to success on the wards, right?
That's right.
And so now we get into a discussion of, okay, this particular student can demonstrate mastery on standardized exams.
Yes.
But now during your clerkship, you also, and this is just day to day, have to demonstrate mastery in your professionalism.
Yes.
That is something that's going to be extremely important during your clerkship years, and that you have to be mindful of. So reliability, how reliable are you? Punctuality, you have to be on wards at a certain amount of time, at a specific time, and that time changes based off of your rotation. If you're on a surgery rotation,
Early morning.
That's just what it is. You know, you're ready, and even the presentation style switches up.
That's correct.
Because I remember my surgery rotation at MedStar, MedStar Washington Hospital Center. And I remember giving a presentation how I would give during my medicine rotation, and the attending was like, "Wait,
that's right,
you're doing too much." And the resident had to pull me aside, like, "Listen, we give the very, for pre-rounds in the morning, it has to be very tailored because you're seeing these patients." And then going down to the operating suite to scrub in.
And Matt, just say this very quickly. It's always one of my favorite stories, and that is when, as you said, you're in surgery, right? And you're presenting as if you're in the medicine clerkship, and then the attendant says, "What are you doing? Why are you presenting that way?" And the scholar says, "Oh, well, that's what I did in my medicine rotation." And the attendant says, "Are you on medicine right now? Are you on medicine right now?" And everybody looks at you.
Right.
And it's "No, I'm on surgery." Thank you.
Thank you.
Present like a surgeon.
Exactly.
And it changes for OBGYN, for family medicine, etc. So understanding professional culture, as you said, and what are the other expectations that change from clerkship to clerkship is important.
Right. So, yeah. Because it even goes down to like the different labs that you have to pay attention to. On surgery, I remember my first presentation on surgery. I remember it was dark in the hallway. It was early morning, and I didn't give the ins and outs, the I's and O's. They're like, what's the I's and O's? And I didn't even know what the term was meant, I's and O's. I mean, I know ins and outs, but I never heard it I's and O's. And so, just having that understanding of the cultural, because my orthopedic rotation was completely different than everything, and so you have to understand the culture, and that is part of the professionalism.
Yes.
Part of the professionalism is understanding the landscape that you are now entering into. And so we already talked about the empathy part, because that is going to definitely be a part of your professionalism, and what your attendings and your residents will be evaluating. How are you speaking with your patients? How are you communicating bad news with your patients? How do you navigate conversations with family members? How do you navigate conversations centered around HIPAA concerns, and so all of these particular things are very important for the professional aspect of your doctoring, because your license at one point, at some point, once you become, official tissue, like we used to say, will depend on it. That professionalism, you keeping that license is going to be very dependent on you practicing and having these professional skills hardwired. So you don't have to, there's no time to figure out professionalism as a medical doctor when you have people's lives in your hands. So these are things that, as you are going through your career, we even want you to come in with these particular professionalisms, but understanding what you need to do in terms of the landscape of what the rotation and that you're currently in is a part of your professional approach to the wards.
It makes a lot of sense, and we should consider at this moment, we hit two additional critical areas. Before professionalism, of course, we talked about, in essence, now how are we learning as we go through the clerkships, which was critical. And if we had one action step for that one that you would use as a takeaway, the goal is to remember each evening or at some point during the day, you need to have identified an available study block and to think about engaging learning around the patient medical condition that you engage that day, maybe one of those, and maybe one new areas as part of your longitudinal learning. And we would do an action plan for professionalism, which is equally important. It's to understand the landscape of every clerkship by doing a lot of excellent observation of your residents and your attending physicians who will model and share with you the expectations. Now, you're coming with some core professional skills, obviously, but then there are nuances, as you said, DJ, that go across the different clerkships that are important.
Mm-hmm.
Very, very insightful.
Very insightful. So, all of that leads us into, this optimizing. We're optimizing how we're going and navigating through this rotation, right?
Yes.
Because at the end, we have the shelf exam and we want to be prepared for the shelf exam. And we talked about some things in terms of learning, your professionalism, and how these particular things sets the stage for the success in the wards. But particularly for the shelf exam, how are we approaching success on the shelf exam, but especially without sacrificing the care of our patients? Because the time is very finite, right? So with that being said, how do we optimize the best that we can on these shelf exams, but then also not have that affect the quality of the care that we're giving our patients?
And DJ, that starts with, we have to have that plan before the start of the clerkship. And it's very possible to do that. And this is why facilitated session is so important, because as you know, typically once one clerkship ends, in most medical schools, it's ending on a Friday and the next one starts on a Monday. Now it changes at some locations, but Friday and then starts on a Monday. And I always say on that Saturday and Sunday, there's some good time for wellness, but there needs to be some targeted time to actually look at what's coming up in the next clerkship. And as it relates to the shelf exam, I always say start at the end, right? What's the date of the shelf exam? 7 days before the shelf exam, I should have finished all of my learning enrichment. 7 full days before the shelf exam. That's a goal. So now 5 days and 3 days before the shelf exam, there are these nice little practice tests called the Clinical Master Series. And they're available to all medical students through your self-testing portal, the MBME.
Free of charge?
Free? No, you got to pay for them on those. Well, it depends on the school, because some schools will give it to you,
and
right?
Your resource, like
in the resources, right? And stuff right, because what happens is that the school can pay for it through a license. Right. Now, I was going to have some fun there for a second and say that sometimes students get it through a wormhole, but that's another story. Okay, yeah. That's right. The Clinical Master Series, a lot of schools will be part of your tuition, quite frankly, will have those for you, and you can complete those on day 5 and day 3 before your actual shelf exam. Right. So you can see there's a system. If you think about, if you've done that weekend before you start, you can look at the end and you can say, okay, if I'm done with all my prep, I'm now ready to do 2 predictive practice tests, 5 days out, 3 days out, and I still got 2 more days before the exam. So that's what I call, sort of the 2 big predictive practice tests. And every scholar should kind of put that on the calendar. So you have to really be organized to do that. Right. Now, as you've done, and I want you to share this, those are like just 3 basic benchmarks. But leading up to that time frame is pretty much everything we've already talked about. Right? All those other pieces that we're doing, obviously keeping the wellness together, we're keeping our gratitude and empathy in place because that drives our learning, appreciation, meaningful learning with a purpose, right? That's going to allow you to be learning on the weekly basis. And of course, you'll be doing a small number of questions. Yes. Right? Did you do that?
Yes.
During the week leading up to the 7 days before. Right. Is that kind of been your experience?
Yeah. So, I mean, as soon as you said that, it literally took me back to the resident room on the my OB-GYN rotation at Georgetown. I just remember being there first thing early in the morning, utilizing those question banks because your The OB-GYN, they have, different
Wise.
professional associations that give you questions, and then also you can access some questions through your university resources if they have them, right?
That's correct.
Now, it just brought me back. I remember being the first one in the resident room, cutting on the lights, sometimes having to find somebody to open the door to get in.
Yes.
And then going over those questions in the morning. And so what I tend to do, because you have very limited time when you're on these wards, so like, again, coming back to the time management, and then also the resource, and making sure you're not resource overloaded. That's going to be very key for that, because, you may only have 30 minutes in the morning or an hour in the morning. And that's if you're making it, that's if you're coming in early,
That's correct.
because typically if you're coming in, especially around the time that clinic is starting, now it's just time to get down, like you say.
That's
get that white
That's
coat
right.
on and
TTGD.
start pre-rounding, chart checking and getting everything ready for your presentation that you got to do later on in the morning with your residents and your attending. So having a very streamlined approach to, I have this one resource, this one Q bank, some of the resources that we just talked about. And I'm using this is going to be my morning. I know I have 30 minutes before the first resident walks in, and that's going to be the time I'm going to use to study. And then when they come in, that's my time to now let me log on and start chart checking and go pre-rounding.
Exactly.
And
you know what's significant? 30 minutes may seem like a lot of time, but scholars, you'll find out on clerkships, 30 minutes is a lot of time. Monday through Friday, that's 2.5 hours.
Yeah.
Across 5 weeks, that time adds up. That's just the morning time.
Yeah.
You'll find that you have to take the time wherever you can. If I can get, 5 hours a week in the morning, and I can get another 5 hours a week in the evening,
right.
Now I got 10 hours. So across 4 weeks, it adds up. That's 40 hours.
Right.
Because all the other time you're seeing patients, you have some free time maybe during the midday, do some more studying, and then you have to rest. You have to rest because you're seeing patients.
So you got to be rested.
You got to be rested.
Right. And I suffered early on from that mindset. And that goes back to that all or nothing mindset.
Yes.
You think 30 minutes is not enough time. I remember, shout out to Henri, my boy.
Henri Francois.
Henri Francois, yes.
That's right.
We would have like 8 minutes before something, and I'm seeing him studying. I'm like, Henri, he's like, bro, I got to take every minute. For me, I'm like, 8 minutes is not really going to make anything. I might as well just, go get a drink of water or whatever. And sometimes that might be the approach. That might be what you need. However, just thinking about, the mindset that you have, because when you have that mindset, then it opens the doors that this is an available thing to do. So if you're looking at 30 minutes as nothing to actually take advantage of because it's not going to mean anything, but you're not framing it from a longitudinal standpoint.
That's
that
right.
30 minutes over 5 weeks, plus whatever additional time that you have in other areas of the day.
Great structured time.
You have a great structured amount of time.
And what seems to be very limited time, because of great demands of patient care, you still have your own personal wellness, family engagement, friends engagement, and you have to rest. It adds up. And so that is a strategic, actionable step to get ready for the shelf exams, you have to take that weekend before the clerkship starts. Take those resources, like you said, they lay everything out and say, okay, my exam is on this day. 7 days before, I must be done with my daily and longitudinal learning, whatever that is. I choose by one resource. And then 5 days before, a clinical master's series exam. 3 days before, a clinical master's series exam. Those are my 2 predictive readiness exams. Everything else is exactly what we said. You're engaging, you're learning, you're empathetic, you're grateful for the opportunity to serve others through medicine. That's going to make your learning meaning and purposeful, right? And that's going to help you actually learn well. And then you're targeting blocks of time, even if it's 30 minutes, and you can actually get a few questions done, and that adds up. So when you get to that day 7 before you have to be doing practice exams, Now you're ready.
Right.
The pitfall, as you know, is what tends to happen with scholars.
In terms of
in terms of that readiness, most times they're still trying to quote unquote
trying
cram
to finish,
right up to the day before the shelf exam, and then the day before the shelf exam they start practicing questions, and that doesn't work.
That's never a good approach. So saving questions to an end, because it just takes me back to surgery, and my surgery rotation was unique because this was right before we went on lockdown, right? So I had the fortunate experience of being in medical school during the COVID pandemic, right? So I recall distinctly, all of the schools were going on lockdown. Like every school was getting, the students were going home, and all of the Georgetown students is checking our emails like Dr. Kumar, Dean Kumar, is what's going on. And so, but I remember, because surgery was just, surgery at Georgetown is intense. And I think at the time it was 12 weeks. It was a 12-week rotation. That in and of itself takes a lot out of you. And then through that 12-week surgery rotation, you have multiple sub-surgery specialties that you're rotating through, right? And so it got to the end, and I know, the schools, we was talking about if we were, if school was going to be, if everybody was going to be sent home. And I'm trying to cram through surgery questions. And I'm like, hold on, this doesn't even seem the same. This looks like medicine.
Looking at it for the first time. That's right.
Looking at it from the first time. I get all the way to almost the end of the rotation. I'm like, this is the way, that transition in terms of that surgery exam and what you experience day to day in surgery is very different.
Majority of the exam is medical management,
medical management,
op and post-op.
Right. But you don't know that.
That's right.
If you don't check through the resources. So, you get a guy like me who's like, I don't feel ready to even start doing questions yet. I'm lost. I don't know, what's going on. So I got to feel that I am, covering some of the material from these different subspecialty rotations before I want to sit down and do questions. But then I sit down and do questions right before the rotation is getting ready to end, and I'm trying to cram these questions in. And then I say, well, this is not even a medical, this looks like medicine. It doesn't look like the surgery context. And I hadn't had medicine yet. So I hadn't had medicine yet. So, you have medicine first, and maybe you can make that quick cram. And, but God, pushed me to really, I had that divine intervention, and shout out to divine intervention, a very good resource. But I had that divine intervention to try to get all the material together, and I felt a good flow. And I brought up the lockdown situation because I wound up not even having to take the shelf exam because we were sent home before that exam. But at the same time, that just speaks to that preparedness, because you think that, oh, well, I'm learning because I'm in the rotation, and you are learning while you're in the rotation. But learning from a practical standpoint and learning for a standardized exam is two different things.
That's correct.
And so you have to make sure that you cover all bases when you're preparing for these shelf exams. There's usually always going to be old exam questions that you have access to. And so you want to at least be able to look at what the test looks like. So this way you can be prepared. So when you're studying is framed based off of what you already looked at.
That's correct. Very, very good insight. And so, DJ, I want to hit one other area that I know is very important to our scholars, and that's how you get feedback on the clerkships, right?
Yeah.
And share with us how that feedback occurs.
So feedback occurs through, now, are you asking for the official feedback, or are you asking?
I love that question. That's right.
The thing.
That's
or
right.
The unofficial way we ask we get
that's
feedback.
Right. So let's talk first about the unofficial feedback. You're going through the clerkship. Sometimes there's feedback immediately after a morning report.
Mhm.
There could be feedback at the bedside, and then there's mid-clerkship feedback.
Gotcha.
Let's talk about that first.
So with feedback, you really want to make sure, especially like the unofficial feedback. We'll get into the official aspects of feedback, but those unofficial aspects of feedback, first and foremost, make sure it's appropriate, right?
Mm-hmm.
So how and who do you approach about your performance? So like you said, it can be after a presentation, after morning rounds. It can be during rounds, if you're having like a sit down rounds in the resident room, or even if you're just kind of walking rounds. These are different areas in which you are, have the potential to show and demonstrate your mastery of whatever it is, and then ask for feedback after. And so one of the things that I used to do, or one of the things that I put in my head early on during clerkship, was to be comfortable with the uncomfortable. Be comfortable with hearing the uncomfortable.
Yes.
And when I tell you that has served me more ways out in so many different ways, even outside of medicine, just being able to hear the uncomfortable aspects about you, right? And so, and that's not to say that everything is bad, right? But just preparing yourself that you're not perfect and you're learning. You're a learner. So don't expect every piece of feedback to be, gold stars across the board, right? So first framing your mind that you are a learner, that you are, a trainee, you're here to learn, and you're putting your best professional foot forward, but at the same time, you're open for correction and open for hearing those areas in which you can improve. So
that growth mindset.
Yeah, that growth mindset. So some quick things that you can do in terms of like, okay, is this appropriate? Is this an appropriate time to ask for feedback? Is this an appropriate amount of frequency to ask for feedback, right? Then once you get those locked down, it's how do you ask for the feedback? So you can do something even as simple as, hey, attending, or hey, resident, what are some things, or what is one thing that I can keep that I did well? And what's something that I, is an area improvement that I didn't do as well? And that's a good icebreaker to engage a conversation about, with your attending or resident, about how you can improve and to make those improvements. One of the feedback that I used to get is the fact that I would ask for feedback. And it was consistent of my letter at, when I was preparing for match. I saw that consistently, ask for feedback appropriately, and applies it immediately, even as soon as like that morning, And so being comfortable with hearing the uncomfortable, but then also being able to apply it as soon as you possibly can, right? Because that demonstrates to your attending and your resident and your evaluators that you are professional enough to hear, to have that collaborative critique about how you sharpen your skills, because the goal is to make you a better doctor, right? And so that you have the professionalism to hear that, but then you also have the ability to apply it, and apply it in real time as fast as you can. So that's going to be a critical thing for your evaluators, because that shows them that you're a malleable learner. I can tell this learner something, this trainee something, and they can adapt very fast. That's a good skill to have as a doctor.
It's also one of those entrustable professional activities, the ability to receive feedback and apply it appropriately. And then on the other side of that, so that gives us a great way to grow professionally during the clerkship, and to own our growth, right, by engaging on feedback. At the end of the clerkship, there is formal feedback that we see in the form of a clerkship evaluation, and eventually you'll see it in what's known as the medical student performance evaluation,
the MSPE.
That's right. Tell us a little bit about that and how that can be important.
So when you go through a rotation, there's going to be several people that's evaluating you. It could be the residents, the attendings, and maybe other medical professionals on that unit. But typically it's going to be the attending that's going to be submitting that formal evaluation to the department that's going to then be logged, right? So every rotation, these the feedback, the evaluation of your performance, your professionalism and learning that you demonstrated during that course is going to be noted. And that can be a composite. The attending may be submitting a composite based off of what they evaluated personally from you, and then a collection of what the residents, evaluated throughout the coursework, and then put that in, this evaluation letter. It's stored longitudinally because as you get to your 4th year and you are applying to residency, you get this MSPE, which is, in sorts, for lack of better words, a summary or a summation of all of the evaluations that you've received during your clerkship years into this composite summary. And then that composite summary then gets pushed out to the different programs that you're applying to for residency, because they want to see the doctoring.
That's right. That's where it is.
They want the learning, but they also, because that doctoring is very, very important. If the professionalism issue might be a lot more damaging than like a red flag with an exam, and so what you want to do is make sure you are really being intentional. And it's not just when you think you're being observed, because really you're always being observed.
That's correct.
You are always being observed. Everything.
Always remember.
Yes.
Who are you when someone is not watching?
Exactly. And that's where I wanted to go, because it's when you don't know you're being observed, that can be the very critical, maker of breakers in terms of how your evaluation is framed at the end.
Absolutely.
So you always want to be cognizant of professionalism. But see, if it's a part of who you are,
there it is,
your
Dr.
early
Jackson.
professional
That's right.
identity, that's not something that you have to cognitively tap into.
Who you are.
It's just who you are. And so that's what we want to make sure.
And it will be recognized.
And it will be recognized.
Positive. That's right.
Exactly.
That's right.
And so, those are some of the things that, I focused on during my clinical rotations was, how do I engage, appropriately asking, appropriate frequency, how do I ask and how do I apply it in real time, and so that was the more informal thing. But then when you have this formal composite letter that's put together, that is that's almost like, your internal CV, your internal resume from the medical school that's going straight from your medical school, which holds weight, to the place that you're trying to get a contract for a job for residency.
That's right.
So you want to always be professional and make sure that composite letter is as pristine as as possible.
Well, that's very insightful, and I think you gave our scholars an excellent actionable step with respect to what they can do to be proactive about feedback, which is to, as you say, appropriately, right, engage your resident or your attending physician. What's one, professional activity that I'm doing well that I can keep, one area of improvement, and then look at the timing of when you do that, but be proactive and just be considerate of how often, et cetera. So you'll learn that. Watch again the attending and the residents to see that modeled. But if you're not receiving feedback, obviously you should start being proactive to engage that. Well, this has been an absolutely outstanding facilitated session on the Clerkship Playbook for Success, right? As our medical students enter the clinical scenario of the wards. What else do we have to wrap up with, DJ?
So I think this might be a good point to have like a clinical story or a ward story.
Yes.
Yeah, to kind of capture some of the things that we're talking about. So, as it pertains to, how our EPAs, this MSPE, how it all, fits. I could just think of a particular situation, and I think I mentioned earlier about HIPAA, confidentiality, and how that is an extremely important thing, an expectation that you should have as a medical doctor, and understanding all of the various different aspects of confidentiality. So I remember early on, and the reason why this stuck out to me is because at the moment, I thought it was such a small thing that, if it never was mentioned again, I probably would not have remembered it. But because it was actually mentioned and somewhat made a big deal of, I remembered it. So I was, interviewing a patient, and the spouse was in the room, and typically you're giving information, and there's multiple people in the room. I knew that I know this is the spouse, but I still understood that there's a confidentiality to my patient, which was not the spouse.
That's correct.
So asking the spouse, and I remember kind of feeling a little bit hesitant about it because I didn't know how that would be received. But I did ask the spouse if they can, step out for a second. And then I asked the patient, well, do you feel comfortable with your spouse being in the room to hear the information, right? And the residents, observed that, and after the fact, they were able to, pull me to the side and say, that was a great thing that you did. Here is how that reinforces the expectations of confidentiality with your patient. And, like I said, it stuck with me because I really wasn't thinking that it was that big of a thing to do. I was hesitant, just like sometimes us students are hesitant about asking certain questions about, the sexual history. I remember that being a big thing, during medical school. It's like, well, how do you ask this and be comfortable asking that? So that's one of those things. It's like, I don't want to be offensive to someone by asking their spouse, or even the spouse feeling offended by me asking them to leave. But my primary goal, as a doctor, not my primary goal, but one of these goals and skill sets that you should have as a doctor is confidentiality. And sometimes that might force you to do something in the moment that feels uncomfortable. But just like what happened that day, a lot of people will thank you for that because it does mean something. To give that patient an autonomy of controlling who is able to hear or witness their medical information is very big and important to patients, and it should be important to you as a doctor.
Absolutely. That's a wonderful example of an entrustable professional activity around confidentiality. And it's also important to journal about some of these experiences because they reinforce your meaningful purpose and the accountability that you have as a professional. But also, you are sometimes asked to share an experience in your residency interview because the programs are also assessing, well, yes, I read everything about your application, but can you give me a lived experience of this EPA? And so that's a good actionable step that not only reinforces your own professional growth, but also prepares you for your residency application if you were asked, or if you're asked that in an interview, but also I think is a personal testament to some of these successful milestones that you can look back on when you journal. That can be an encouragement as part of your professional identity.
Journaling is very important for those aspects. It's important, for being able to have that reflection about what's happening in that clerkship. Is reinforcing the learning. I had during my my family medicine rotation, one of my attendings was very adamant. She said, I don't care. Every day you need to go home and read something, a study. I don't care if it's just the abstract or the, about something related to a case that you saw today, right? It reinforces, right?
Yes.
And so, when we talk about the journaling and the reflecting, it reinforces those empathy pieces, that gratitude piece. But then it also mirrors the things that is essential for residency, because when you talk about the ACGME, and can you remind us what the acronym stands for?
Oh, that's the Accreditation Council for Graduate Medical Education.
Yes, he's the
guru on the
acronyms,
acronyms.
right? So ACGME mandates certain things, and these. This is the governing body that we engage with as residents, but they mandate fatigue mitigation and well-being initiatives as part of the program. So having some of the things that we talked about today in terms of learning during your clerkship, in terms of wellness during your clerkship, are things that is actually evaluated during residency.
That's right.
And so if you are putting these practices into place right now, you're already setting yourself up to fit right into the landscape of residency when you go there. And then obviously at that point, you just got to do some, adjustments of
adjust to the new landscape.
Adjust to the new landscape, but you have a fixed model from what the governing body
requires you
to do during
and
residency.
will evaluate you on
right.
it. That's
because M3 and M4 year is set up to be, kind of, like we call it in the NBA, you got the G League and then you got the NBA, you got the MLB, you got the minor leagues and you got the major leagues.
Right. It's the minor leagues of residency.
It's the minor leagues of residency, right? And so if you have a governing body that's saying, we value fatigue mitigation, we value wellness and balance, we value these areas of engagement and oversight and supervision between the learner or the trainee and the institution that they're a part of. Why would you not, take this as, take these things as examples right now as an M3 or M4 and making sure that they are a part of your solidified plan going into residency. So we're not just having a conversation about what to do to take off on day one during clerkships. Now, how do you take off on day one during residency?
And the preparation starts now.
The preparation starts now. And so I think that is a good closer.
Yes, I was just thinking that.
To this season 3. So this is more of an introduction to what our medical student journey is. So season 1 and season 2, we spoke to our pre-med students. So this season we spoke to our medical students, and we'll be back shortly with season 4, where we're going to take a deep dive into your USMLE STEP exams. So step 1, step 2, and then also what does the match process look like, right? And so that's going to be on our next season of Facilitated Sessions, Ascension Medical Educators. Thank you for stopping by.
And we look forward to seeing you in season 4.
See you.